it's 6:30 now. So we'll start off, if it's okay, with Dr. Anwar Danji. He's a very experienced dentist. He's had his own practice. He's been heavily involved with the LDC, and he does a lot of work with the GDC at the moment. So we are very blessed to have him. And if you're happy to start off, that would be great, please.
Okay, am I audible?
I can hear you. Yep.
Is everybody able to hear me? Because I'm not very comfortable with this gizmo.
Hi, Dr. Anwar. Everybody can hear you. Your voice is very clear.
Okay,
feel free, and the stage is yours, sir. We will be looking forward to listen to your advice and your intakes during the COVID crisis. Thank you.
Excellent. So
before you start, before you start, I just want to say one thing. If everybody can except for you, everyone can mute themselves, it would really help, just because there might be a lot of background noise. Thanks. Brilliant. Sorry, go ahead, please.
Okay, so I've been asked to talk about how to respond to COVID-19, providing treatment in these uncertain times, and all the challenges that the dental profession is facing with a GDC's perspective. So I thought that it'd be easier if I clarify the guidances in 3 different areas. So the first area would be like we are working in a non-dental setting. The second area would be regarding providing remote advice and prescribing. And then we can just talk about the treatment in primary care setting. So as a clinician, you have to make clinical judgments. At the same time, you have to consider guidances which are available, and you must base your judgments on an appropriate assessment of the risks involved in all the decisions that you make. So working in non-dental settings, the NHS, as you know, is increasingly asking dentists and other care professionals to be ready to support the wider COVID-19 response by using their professional skills and experience outside the normal range of dental and oral health activities. So as a regulator, I think you'll find that the GDC would want to support this kind of activity. But their main concern would obviously be that you as a registrant in your activities do not compromise patient safety. So when you are providing support to the wider NHS, the same basic principles would apply like they would in any other situation as far as dental treatment is concerned. And the test would have to be whether you are trained, whether you are competent, and whether you are indemnified for the task that you're undertaking. There are many tasks in the wider health service that can be performed by dental professionals because you'll be drawing on your existing professional skills and experience. For example, swabbing, proning patients in the intensive care areas, counseling, assisting. But you should be satisfied that you are competent to perform the task that's been asked for you to be done. You have to be given the necessary training to equip yourself to be able to perform the task. But it's your judgment really to make sure that you are trained and you are competent. Obviously, you will have to take into account the guidance that the health service is preparing on mapping between dental skills and wider medical skills. There is a document out on that, and it has the 3 different columns, and it talks about the task, the additional tasks that is expected out of you, and also which professional, care professional can do which task, and whether there is training required or not. And you would have to basically look at that also in more detail. The GDC does not expect you to limit yourself to specific activities set out in the scope of practice. I mean, the scope of practice is there. It's not irrelevant, but it's really a starting point, isn't it? When you're considering all the other wider tasks which you appropriately perform, like your BDS, the scope of practice is just a starting point. I mean, for example, Monty has become an implant specialist. So he's added all those skills and all those other expertise in his area, so he can then widen his scope of practice. As far as the GDC is concerned, I don't think that they consider this to be a constraint in your ability to support the COVID-19 response. They are quite happy to see you guys do these other activities, as long as the three things that I talked about earlier are in place. As far as the issue of indemnity is concerned, I don't think that's really a big issue, because where support of this kind is provided to the NHS staff, for example, the Coronavirus Act is there, and Section 11 covers very clearly all the areas where the government and the NHS will support anybody who is doing a wider area work than is required. It covers for liabilities beyond the scope of your existing cover. But it'll be a good idea if you're working in the NHS and you're taking support of this Coronavirus Act, then that's fine. But if you are not got the NHS cover on you, then you may want to check with your own indemnity to see if there is any way in which it needs to be beefed up. But I'm pretty sure that the NHS cover will be adequate. Going on to the second point, which is the remote advising and prescribing, where patients cannot come to the surgery, you have been asked to provide advice remotely and to work with patients to defer the need for active treatment through the use of pain control and antimicrobial treatment. Granted that it is difficult for you guys to make a clinical assessment if you are unable to pick up on the non-verbal communication and carry out an examination. I know that it's difficult diagnosis based on that. But if you follow the basic principles of the GDC's endorsed guidance on remote consultation and prescribing, there is a document that they've taken out, which I think is about 4 or 5 pages, and it lays out exactly what you should be doing. So have a look at that paper. The specific circumstances of COVID-19, I think the key requirement is that you make an appropriate risk assessment. This risk assessment should be recorded and should take into account the infection risk of COVID-19, both from and to the patient, as well as the apparent seriousness of the need of the treatment and the extent to which it has been possible to make a clinical assessment. So I think recording is really the key here, making an appropriate assessment and then documenting everything that you are doing would actually be appropriately okay, because if you were to be challenged, then I think there will be a way of defending the challenge. When you're prescribing remotely, just be sure that it is in the best interest of the patient and that you have no other viable alternative. Where appropriate, it should also take account the NHS guidance on treatment which should and should not be offered in a primary care setting. And I know this guidance is changing by the day. And when we come to the third part that I want to talk about, which is the treatment in dental primary care settings, I think the guidances here will probably be more important, and we can explore that. For the duration of the COVID-19 epidemic, I think infection control is of paramount importance, and even greater than normal care will need to be taken to minimize the risk of infection. In many cases, the right approach would be to stop providing treatment altogether. And I think we have been there in the last few months or so, that we've not been providing any treatment, just consultations on the telephone triaging. But as we go along, post June 1st or in July, there will be need for us to look after our own urgent care patients first, and then maybe do more invasive treatment. So I think NHS dentists will need to adhere to the directions given by the CDO and the updates that they give. So you have to be very, very clear about making sure that you're looking at all the guidance that are available. And I think there might be a a good idea at this stage to talk about the steps that you want to take. And maybe there are 4 steps that I think you need to have in your mind in terms about all these guidances, because they're coming out from different places, they're coming out different days, they're coming out almost from everywhere. So first of all, check that the relevant updates and the guidance daily. So you want to look at all the websites, the CQC, the BDA, the faculty, Department of Health, CDO. Make sure that you're actually updating yourself. Secondly, I would suggest that you nominate a lead person in your practice who is in charge of disseminating the information and the advice that you're picking up on a daily basis. Thirdly, I think you should keep a log of everything that you're doing. The reason for doing this is that then you'll be able to demonstrate, if challenged, that you are actually up to date. And the fourth point, I think, very important, is that always look at the website and don't just look at the saved documents, because you might be caught out in the sense there might be a new document that's come up and you're looking at an old one that you've uploaded. So make sure that you actually go onto the website directly and deal with it. And also remember that guidances do not cover every scenario. So use your professional judgment. From a regulatory perspective, the central question is again whether an appropriate risk assessment has been made. If treatment is offered, it will be important to record the specific precautions in place to ensure that the risk is appropriately managed for the particular treatment that you envisaged. I don't think that GDC doesn't actually set out any clinical standards, because that is not their job. Their remit is a regulation aspect. It's not a trade union like a BDA. So what you want to look at is all the guidances that are given by the 4 nations authoritative source of guidance given by the Department of Health. The GDC can only ensure that this guidance is readily available. So if you go to their website, they will just signpost you as to where the guidance is present. And therefore, you need to find it yourself. And the GDC feel that it's no need to duplicate all these guidances again. Having said that, when they got out the standards, I think the first standards that came out many years ago was in about 5 or 6 pages. And now you've got a whole booklet of the standards of guidance, which actually is very prescriptive. So on the one hand, the GDC wants to say that they don't want to be prescriptive in giving guidance for COVID-19. And yet on the other hand, they've got like a 40-page document very prescriptively telling you what the standards should be and what is expected out of you. So there's a bit of an anomaly there. Along with other healthcare regulators, the GDC have made it clear that the context in which treatment is given is very relevant, and that it may be necessary to adapt procedures to that context. So I think there is a little bit of room here for maneuver as far as the present climate is concerned. Because the GDC, I think, has got no interest in penalizing the well-grounded professional judgments about how best to meet the patient's needs, including where the judgment is reduced to stop activity, because they're anticipating at the moment a little shortfall in activity happening. So they don't really want to be too heavy-handed in these unprecedented times. Much of that in turn comes down to a pragmatic assessment of the risk, where the risk of infection from a patient to a practice staff or the other way around is greater than the risk to the patient of not providing treatment. It will be in everybody's interest not to go ahead. So this is not the time to be heroic. This is the time to actually make this risk assessment and then make a judgment based on the evidences that you have in front of you. That is increasingly likely to mean that there are some patients who should not be treated and some treatments which should not be offered in general practice environment to protect the safety of the dental team and other patients. Where those lines are best drawn at a given time will again be for the health authorities of each nation to decide. The GDC say very clearly that they will respect professional judgments made on that basis. And they are not facing, as we are facing, uncharted territory at the moment. Whether higher risk treatment is urgently needed for higher risk patients, each nation is providing clinical environments where the treatment can be safely undertaken. So I think that's basically just to set the scene forwards. I mean, there are going to be quite a lot of individual cases that will come up in the discussion. I'm quite happy to have a look at them. Just one or two that have come up to me very, very frequently by many people. This grappling about whether to use the SOP or the guidance in situations where, for example, is an antibiotic cover required or not. So the NHS 111 will only treat patients at the moment, triage them, unless the antibiotic cover has been offered in the first place. And then there is this dilemma between the dentist as to whether an antibiotic should be prescribed or not. You want to grapple between the SOP and the guidance, and you want to decide whether to prescribe one or not. I think you have to look at the guidances, and the faculty guidance on antibacterial prescribing is quite clear that when definitive treatment has got to be delayed, for example, when you're referring a patient to a specialist service, although there may not be signs of systemic involvement or swelling or fever, you may actually prescribe a patient an antibiotic just so that the patient's treatment is being delayed because it's being treated in a hospital environment, for example, the urgent care dental center. So there are, I think, mitigation areas and circumstances where you can prescribe an antibiotic even if there is no signs of systemic involvement. I think the key here would be to document everything and your reasoning as to why you're doing what you're doing. But, for example, there is no indication for antibiotic to be prescribed where there is acute pulpitis. So you can't actually do that. If it is acute pulpitis you're dealing with and that's what your diagnosis is, then you have to limit the cause, and maybe analgesics might be a better option. So I think I will stop there. I think I've taken just a little bit over my 10 minutes allocation, and then see how things progress from here.
That's great. Thank you so much. That was actually very comprehensive, and you answered a lot of the questions that were actually put forward before we organized this. So thank you very much. If you're still here later on, I'm sure there'll be some questions that come up. And
yeah, sure. I'll sit through for as long as I can bear it.
Thank you. Brilliant. Thanks. Perfect. So next, basically, we are going into a little bit of online dentistry and tele-dentistry. And we've got with us Jiten Master. So Jiten qualified from UCH quite some time back, and then following that, he went to the USA for his prosthodontics training. And after that, he carried on staying there for about 25 years. He came back a couple of years ago, and now he's mainly working in private dentistry, and he's going into tele-dentistry a little bit. So, Jiten, if you're happy to, take over and tell us what you think about how things will go forward, and how it would be useful to get involved in that.
Sure. Okay, great. Thank you, Roshan. Thank you very much, everybody, for giving me a little time here. Can you hear me okay? Okay, very good. So as Roshan said, I'm a dentist primarily, and actually part of my experience that I had in the US, I was working in a home sleep testing company where we had some interaction with telehealth and telemedicine to speak to patients to basically prescribe tests for sleep apnea. So it was a concept that I've been familiar with and for some time. And when I actually felt like at some point in time, it may become something that would be helpful for dentists to be able to provide as a way to get patients to interact with you in a less clinical environment, a service that you could provide that would help answer some questions, get the patients to know you, get you to know the patient, and in this particular time with COVID-19, there are some questions that came up with, okay, so how are we actually supposed to interact with patients at a time when, as Dr. Anwar says, there is this question of how do we document a call? How do we show that the steps that we've taken are correct, and that later on, should something happen or should there be a need for information, it's at hand to then transmit that information to whoever needs it. And hopefully it's not the GDC, because you've done something that was inappropriate. So, but then, it's very easy to pick up your phone and, talk to the patient on the phone. And now we have video on our phone too. And initially that's what I was using. And then I thought, well, okay, I can't really record what's on my phone. How do I document it? So do I just put it on a word processor on my computer? And all these questions started to come up, and it became more relevant at that point to do exactly what's in line with. So I read the GDC regulations and stuff, and it seemed like, as Dr. Anwar says, you have to assess risk first of all, and there is a duty of care that you have to provide to make sure that you are treating the patient appropriately, and that whatever you do decide, there's a basis for that decision. And so a tele-dentistry platform is not necessarily just being able to do a video call like we're doing now over Zoom, but it's also having something in place where you can take a medical history if you need to, a dental history if you need to, because this is maybe the first time you've spoken to a patient because they're a new patient or they haven't been around for a while. And having that documented in a place where you can then transfer it to your clinical practice software when you need to, or transmit some information to the patient. So Roshan was one of the first people that we piloted this with, and we wanted to see how, whether it was at any use to dentists. So when would you use it? How would you use it? Is it easy to use? So initial feedback's been very good from patients. They value being able to see the dentist. And I think Dr. Anwar did also talk about non-verbal cues, which you can't really see over a phone. When you can see the patient and you're talking to them, you can see how well you're communicating and whether or not whether there's something there that the patient's become anxious about, or they haven't understood something that you said. So that's really what the tele-dentistry platform is. And actually at this point, the greatest interest is in trying to find out from dentists, a couple of things. I just written them down here. How would it be useful to you? Is this something that you found you've needed at this particular point in time? Have you had problems of, okay, how do I, if you have access to your software at the practice, you can enter all that information in real time. But if you're at home and you don't have access to it, how are you documenting what's happening with the call? How are you communicating with the patient? And what difficulties or problems have you had in communicating with your patients that a tele-dentistry platform might solve? So my presentation is quite short. It really is just the introduction of how this came about. And actually, I'd be very grateful for some feedback on, whether members of this group feel like this is something that they think they could use now. And as time goes on, I think the provision of dentistry is going to change. We're going to see fewer patients in our practice. There's going to be costs associated with every interaction, and being able to speak to a patient about something that is either advisory or a question or just treatments that they're interested in, this might be the way that it's adopted. So I see a question here. So how do you record a video consultation? Well, actually, on Zoom right now, I believe this is being recorded, right? I think I see the flashing thing. So right now the platform is using Zoom. Zoom is quite common. The use has actually skyrocketed at this time. So you record the conversation. It'll be through Zoom currently on the platform. Now, I spoke to the indemnity people, and they said, well, it's always, the question then is, where is it stored? So ultimately, at some point in time, we would want to provide a service where that video consultation is stored. Obviously, that requires access to big servers and storage facilities, but that is one of the things that I would want to sort of find out from you. How valuable is it for you to be able to record your conversation? I think it's a video conversation would speak for itself in times and in cases where something happened and you're in front of the GDC and the GDC says, well, you know, how did you come to make the decision that you did? Well, you have a video recording and it could be very helpful to you. It might also damn you and condemn you, unfortunately, but it is evidence of what you did. So if you have a good basis and you are practicing dentistry as you should along the GDC guidelines, then we think this is a further benefit to recording and making a record of that. Would the WhatsApp video be better as it is encrypted? Well, there is, so there's a question here. Would the WhatsApp video be better as it is encrypted? Well, yes and no. You'd have to look. WhatsApp is peer-to-peer encrypted. But again, it's not just a question of being able to do a video call over your phone. It's also, how do you document that call? What processes do you have in place to make yourself available? So this platform would have a calendar where you set the times that you're available. So the patient makes an appointment with you, or you could in your office set appointment times for certain consultations or certain treatments that you feel would be amenable to this type of consultation. So it's the Tele-dentistry platform is an all-encompassing thing. It's a way to schedule a patient, it's a way to video conference with them, and it's a way to document your call, and then after that to interact with your patient in follow-up and other things you may want to send to them. So yes, WhatsApp is what we've had to use, and right now I think there is a position from NHS England that they're not necessarily looking at, they're not being very strict about the security of how you're interacting with patients at this time, but in time it will become a little bit more stringent.
I think that's brilliant actually. And I think the other thing with WhatsApp is maybe you can have a practice phone, but for me, for example, when I'm talking to patients at home, I don't really want to give out my number. And I think with a video call, you'd have to disclose your own number. I think the other two advantages, I was talking to your colleague Manu, is it's like you said, there will be some downtime between patients and we can use it at that time. But also if this didn't happen, instead of doing, like some practices would get involved with pre-Invisalign consultations and things like that, I think that would be taking a lot of clinical time with all the associated overheads for the principal. And I think this would also, be quite useful in that sense. Brilliant. Thanks a lot, Jitan. That was great. Thanks.
You're welcome.
Perfect. Next we have Wasim Fazal. So Wasim is in a very unique position because he pretty much ticks all the boxes. He's an associate, he's a principal, he does surgical dentistry, he does cosmetic dentistry, and I think he's had some experience with tele-dentistry as well. So it's great to have you. Thanks, Wasim.
Thank you very much, Roshan. I hope everyone can hear me. Good evening to everyone. When I first received this invitation from Roshan, he asked me to have a little conversation with everyone based on being a principal, being an associate, and talk about how to maintain your value within your practice necessarily by doing things. And it was quite useful that Jiten was just before me, because I've been doing remote consultation and remote dentistry now for the last 3 months, and got some fantastic results to share with everyone as well. And I can probably tell you how we've implemented it and moved on within the practice field. So it's kind by natural association that looks like that followed quite nicely basically for us. But very briefly, I just want to say, this is obviously a very unique time. And as principals, my first advice would be is don't panic, okay? The reason is, yes, we're always looking at the situation thinking, what are we going to do? We're all checking when the CDO are going to let us work again, or we're looking at law firms to see, can we go back into dentistry? But actually take a step back, use this opportunity. This is a great time to really reassess everything within your practice, get to know everything within some of you are new owners, some of you are not been practice owners for that long. So this is that time now to catch up, just to get to know everything. The most important thing I will say, and people often laugh about this, but invest time and effort in your staff and your associates as well. The reason I say that is because, remember, COVID is affecting them as well. It's affecting them massively, okay? When this is all over, and it will be over, you will need your staff with you to stand by you, to rebuild, to regenerate, to redo everything within the practice. If you have invested time in them, if you have invested your energy into maintaining their morale, you will see massive, massive benefits going forward. Don't make the mistake of thinking you're going through this alone. They're going through this with you. And a lot of staff are emotionally attached to your business as well. So use that fact and use that energy that you've got within it. As associates, you have a responsibility not to think, well, it's not my business, it's not my problem. No, that's the worst thing you can do. Because right now, the one thing you need to do as an associate is add value. How do you add value? And I'm going to come to that with the tele-dentistry side of things, because again, what has added value to my practice is actually not necessarily myself, but actually more my associate. And it's this whole two-way situation where an associate buys into a practice and really, really works hard to ensure that this practice sees through this. At the same time, the principal looks after the associate. So please maintain that relationship. When we started this whole, when we ended up in the whole COVID situation, we were already as a practice set up to do tele-dentistry. We used SmileMate by digital monitoring. We've been doing digital monitoring for our Invisalign patients, but gradually we've been moving towards using virtual consultations. So the figures are, you'd be surprised. So we've continued our marketing or explanation of what services we offer. In 7 weeks during the COVID period, just to give you an idea, we've done over 100 virtual consultations for Invisalign. Yeah, we've had 60% uptake of people who have paid a deposit to want to go ahead with Invisalign post COVID. So that's a phenomenal return, and that's okay. You're looking at it in a situation is there's no income coming in, but actually you're working to create the groundwork for yourself going forward. I also have a really large Dentplan list, about 800 patients on this Dentplan list. And you can imagine the people are paying a monthly fee on a regular basis. And so me and my associate Bhavin, who runs Aligner Alchemy as well, we sat down and thought, okay, what can we offer to Dentplan patients that will make us think, how do we protect our goodwill, frankly, because they're paying a monthly fee? And again, remote consultations, SmileMate. What happens is simple phone call conversation, send them a link, they upload their photographs, we get a whole report based on what the teeth are like. It's important to stress, and I think, to make sure that we know this does not replace a consultation, okay? But it's an additive to your situation where a Dentplan patient or a patient feels a part of a unique service that they're being offered within your practice, okay? So that would be my advice, to start looking at SmileMate and monitoring. So we looked at Dentplan patients, and our rate of drop-off, considering it's a COVID time, has been 2%, which is not bad. And the reason we've done that is because we've actually managed to reach out to all our patients, trying to be, up at the top with remote consultations as well. So in summary, because I I'll keep it short. It's fairly obvious what I've just said and everything. As principals, don't forget, invest in your staff. Make sure you are at the edge of everything and know your business inside out. This is your greatest opportunity to do that. As associates, make sure you are invested in your practice and you are doing the right thing by them, basically, as well. So that may mean going in, doing virtual consultations, adapting to the changes that are within the practice. As a practice as a whole, don't sit there thinking this is it, there's nothing out there for us. No, this is an opportunity actually to really build a lot of groundwork. If you haven't introduced any form of tele-dentistry in your practice and you are looking to do it, please DM me. I'm more than happy. Roshan's got my details as well. I'm more than happy to advise anyone. I work, as I said, with Bhavin, who's my associate, and Alina Alchemy, and we've set this whole thing up brilliantly, and it works really, really well. There's no reason why it won't work for everyone else as well. Yeah. So that's really where I come from. Thank you, Roshan.
No, brilliant. Thanks, Hussein. That was very, very useful. There's a question here. I was wondering if you can give us your input on it. Basically, if this Sam is asking that if we're going to have longer slots for patients, we are going to end up seeing fewer patients. And do you think that would have an impact on opportunities for associates and hygienists and therapists? Or how do you see that working out?
No, to be honest, in my opinion, no, because I think what we're going to be doing is, as a workforce, we're going to just have to adapt the way we work rather than change the way we work. We're not looking at making wholesale changes in terms of getting rid of this or getting rid of, no. I think it's just, we all just need to understand we're just going to adapt the way we change how we work. So for example, instead of doing like, whatever, 10 checkups in the morning or so, you may be, your associate or yourself, you may do 10 remote consultations, basically. Yes, whilst that nurse is free because you're doing the remote consultation, it might be that an AGP procedure needs 2 nurses to clean 2 sets. Do you see what I mean? It's just about being sensible and working out how we can work. We're not used to it because obviously we're creatures of comfort. We're very used to how we've always been set and how we've always worked. But that's what I'm saying now. It's time to just take a step back, don't go crazy. We just have to look at it and adapt to the change. And I believe this strongly. Those who adapt to the change fastest will be the ones who are the most successful. And this is something that actually one of our later speakers taught me at a very early stage in my career, Monty. Those who adapt to change fastest are the ones who will always be the most successful. I've taken that. I'm passing that on to others as well. Do it.
Brilliant, thanks. There is one more question on my WhatsApp. Someone's asked, are you charging for remote consultations or not?
Absolutely not. No, we are not charging for remote consultations. What we are saying to the patient is, and look, every demographics in every area is going to have a very specific way they do it. So obviously for Dentplan patients, I don't, because that's a service we offer. But say, for example, for an Invisalign consultation, we take a £10 refundable deposit, basically. Now, what that basically means is they're not wasting our time. So we go in, we have the whole remote consultation. If they decide they don't want anything to do with us at the end of it, we give them the £10 back. But as I said, in 60% of cases, they say, you know what, can we put a £50 deposit and hold that price till whenever COVID starts again? And that's what we have found, basically. Those who are serious will pay the £10. Those who are not serious will go away somewhere else. But each practice to their own, each horses for courses. So, and I'm more than happy to talk to anyone, give any advice that I can. And really, it's just about trying to help each other and just make sure we can really emerge from this a stronger force.
Perfect. No, that's great. Perfect. Thank you very much, Hussein. Thanks.
Okay.
So next, basically, we've got Sadiq. He's an accountant with SP Winshaw, and he basically has been dealing a lot with dentists. He's been involved in buying and selling practices as well. So Sadiq, it's great to have you here. If you can give us some insight on how you see things changing going forward, practice valuations and things like that, it would be great to hear.
Yep. First of all, thanks, Roshan, for inviting me into this Zoom call and giving me the opportunity. When Roshan spoke to me earlier on, getting me involved with this call, I obviously decided to break my topic down into what we are currently facing, both for associates and principals, and how things will be moving forward in terms of practice valuations, you're getting access to funding, etc. So um, let's start with what the current situation is. So obviously, one of the most important thing at the moment while we are going through this crisis is obviously cash flow. And I would urge both principals and associates to look at your cash flow and obviously plan on the based on the worst case scenario. There's obviously a lot of government help available, and for NHS practices, we understand that NHS is still honoring the contract and the associate pay has to continue, etc. Whilst the most affected is the private practices, where income has completely stopped or dropped significantly for those with lower levels of planned patients, etc. So there's various things that the government has set up. One is the CBIL loans, the bounce back loans, etc. It is also a time and by the way, the CBIL loans and the bounce back loans are accessible by associates as well. All you will need to do is obviously convert your associate account into a business account. But those facilities are accessible to associates as well, and it's interest free and capital repayment holiday for the first 12 months. Following that is a 2.5% interest rate, which is not bad considering the current circumstances, and it's government guaranteed 100%. So if you're unable to pay it for any reason, obviously the government guarantee will crystallize. It's also a time for basically principals, especially principals with multiple practices, etc., to reflect. And maybe it's a good time to sort of catch up with your finances to see exactly how your practice is performing against sort of national average. For example, your NASDAQ percentages against how your practice is performing. Look at how year on year your practice has improved over the last couple of years. What strategy are you going to use or implement for future growth, and things like that. As for associates, it's also a time to sort of look back and say, look, okay, this is my target, this is what I have been doing, this is where I need to be. And it's all about looking at if you want to become a practice owner, then it's also a good time to start looking and benchmarking certain practices that you would like to progress with once post COVID. Looking at it from a recent transaction point of view, from our case, we had a couple of clients who were in the middle of transactions on buying and selling, and none of those have stopped. Basically, banks are still supportive of dentistry. There have been they're sort of skeptic about wholly private income, but if you have sufficient amount of NHS and plan income, the banks are still very, very supportive of the sector. We all know that they all realize that the sector will bounce back and things will get back to normal, although there may be some changes on how you guys practice and the cost structures, etc. Goodwill values moving forward. Our opinion is that the NHS practices will hold goodwill values. Again, it's dependent on what cost implications are there and the methodology of working moving forward. Basically, if your PPE costs are going to eat into your margin, then obviously it is likely that it will impact the goodwill valuations of the practice as well, because your UDA values will not go up unless there is some sort of a negotiation with the NHS on contributions into PPE costs, similar to the way they contribute for your business rates, etc. But that's all an unknown territory at the moment. Private practices, yes, I think will see in the short term an impact on the goodwill valuations, simply because of the fact that in a situation like this you lose all your income. And but again, it's also very important to secure that goodwill by regularly keeping in touch with your patients, by sending out mail shows, by sort of, um, if you had appointments booked in the next, during this period, by rescheduling those appointments, by sort of, keeping in touch with those patients and seeing if there's going to be any change, if, there's any way you can assist them or help them by, providing them any, advice over the telephone or remote advice, etc. So that's one way you can maintain it, because any 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 practice that obviously records pre-COVID income levels in a short time post-COVID will obviously maintain its goodwill values. Yeah. Access to funding, as I said before, it is very much the sector that is sought after. Banks are very supportive. Pre-COVID, we were looking at up to 100% loan to values on practices where property was included, or up to 90% with some lenders, 80% on goodwill values. So we may see a slightly different sort of, or more stringent sort of loan to values there, or depending on how the whole goodwill values pan out post COVID. But the banks still remain very much supportive of the sector. Yeah, and I think I'll in terms of associates as well, one thing I wanted to mention, in terms of current help available, the self-employment income support scheme, that is available for all associates. I mean, we have had questions from our client base as well, where, oh, but we're still getting paid on the NHS for the NHS work, but then you have technically lost out on your private income. So if your private income, if the grant value is less than what you would earn privately in a 3-month period, then we don't see any harm in being able to apply for the self-employment income support. But then again, if you were a dentist who was doing a lot of private work, then it is highly likely that your income will be more than 50,000 anyway. So from that perspective, you might not qualify for the grant.
Perfect. That's great. Thank you so much, Adi. That's really good. So basically, one of the questions that we did have was, if you were thinking of buying, your answer is basically this should not stop it. If you're thinking of buying, still, if you find the right practice, just carry on.
Yeah, if you find the right practice, you can carry on. I mean, you could try and structure the private element of the deal on an earn-out basis, where you can say, look, this is what your private income was pre-COVID. This is the multiple of the goodwill. We will pay for the goodwill, but then there's a clawback based on a private performance post-COVID on a similar period. So people will accept some sort of earn-out structures as well at the moment.
No, that's brilliant. Perfect. Thanks. If there's any other questions, we'll get back in touch with you if that's all right.
Yeah.
Great. Thanks. So next, we wanted to hear basically from a lab technician's point of view. I don't know if we still have Mazen here or not. He did text me privately saying that he was struggling a little bit with his internet. So if he's not there, that it's fine. But basically, we just wanted to get a rough idea about what labs are doing at this stage, whether dental labs are thinking about the type of work that they do will change or not, whether there'll be fewer, for example, crown preps because of the aerosol and more, I don't know, Invisalign or aligner sort of therapy things, and or what will happen to the lab bills? Are labs likely to increase their prices or not? Mazen, are you there at the moment, or do we have a bad internet connection? I think we don't have Mazen at the moment. If he does join in later on, that would be great. But next we have my boss, Muntazir Ali. He's been involved in a lot of practices, buying, selling, and he's one of the most efficient people I've ever met, and the most financially savvy people I've met. So Monty, what do you think of what we've been talking about so far? Any thoughts? Sorry, you're on mute at the moment.
Sorry.
Perfect, they can hear
Can
you
you hear
now.
me?
Yeah, yeah.
See, whenever you find yourself in a situation like this, which is a very complicated situation, it is very similar to any situation, difficult situation in the clinic. You need to step back. Just step back and stop. That's how you don't cock up your surgical extraction. You step back and sit down. And this situation just now for different people is different difficulties. So if you're an associate, you're a principal, you're a VT, you're 2 years into qualification, you sit down with a piece of paper and a black pen or whatever, analyze what your situation is. So you got to differentiate the principal situation, associates, youngsters, whatever. Everybody's situation is going to be different. Everybody's going to lose a lot of money. Practice revenues are going to drop by, some practices are doing, say, 50K a month. They have lost 150K revenue-wise. They've still got bills to pay. They're taking out loans to pay this. The revenue is not going to go up for another 3 to 6 months. So you're looking at a loss of 200K on a practice grossing 600. Nobody is putting the figures like that. But if you lost 3 months, your insurance doesn't cover you, and it's going to take 3 to 6 months before you start prepping. So your gross is going to fall by at least 30%. You trying to sell your practice in this market is not going to happen. No one's going to pay for it. If you have a big NHS contract, yesterday Christie's was selling a practice, was it 2 days ago? 286,000 gross, of which 170 or something, 87 was NHS contract, 100 was hygiene. It sold within 30 minutes, cash buyer. This week, with the value of NHS contract. I phoned him just to find out. So it's different situations per practice. But you will be surprised, post-COVID, private practices will do very well. Because they are used to being at a standard these people are prescribing. Right? What your operating procedure will be, private practices are almost there. It's just a question of tweaking. In a busy NHS practice, when you are seeing 15-minute patients, they're going to have a lot of difficulty to maintain the targets. So the NHS has only got 2 solutions. One is to give you an extra UTA per patient and reduce your target by 1/3 if you're going to spend 30 minutes in between patients letting the air clear out. Which one do you think they're going to do? None, because they don't know. They don't know what to do. And that is the reason we are being delayed to go back to work, is because they don't know what to do. That's why they are stuck in a sort of between a hard rock and a very hard rock, because they don't know what to do and where they're going to find the money. And they can't stop NHS dentistry because people need it. I personally think the UDCs might become permanent, right? And then all those who can afford will go private. I'm really hoping that's what it will become. So these UDCs, they're expanding the scope as well. For anybody who needs NHS urgent treatment, they'll go to UDCs. The private practices will increase their plan and they'll see the kids on plan or free. And NHS will be just, you walk into a UDC and you're done. That's what I think is coming. And I hope it does. Because most private mixed practices are subsidizing their NHS. It's just cash flow you're using, but you're actually subsidizing the NHS. And it's probably time to either break off completely. That's number one, when you're a principal. Number two, how is dentistry going to change? I totally agree with Jiten and Wasim. There's going to be a lot of telecommunications, a lot of free consultations, mainly for Invisalign. I agree there with the apps and things you can do. Any other dentistry, it's not going to happen. The current advice of AAA is completely contradictory to dental treatment. We've always been told not to give any. How many times do you need antibiotics in dentistry? You actually got to treat the cause. So just now, they're telling you to treat symptoms. It's completely wrong. AA advice is wrong. But they don't want you to do anything. The UDCs are full up. Personally, they've messed it up big time. They should never have closed us. They should have just told us. And Roshan, yourself, you found the GDC. You spoke to the lady Karen. What did she tell you? She said, we never told you to close your practices. We told you to stop routine dentistry. Yeah. Exact wordings from the GDCs. What was her name? Karen.
Karen, yeah.
Yeah, she told you, we never told you to close your practice. Right? We don't challenge. All our bodies are useless. We have like 7 different people talking for us. We have Scottish CDO, we have English CDO, we have this and that. Nobody tells anything. All of us want are 5 bullet points. This is what you need to do. But nobody's giving you that. But I was quite glad that you took the initiative to call the GDC, and they said, why aren't you seeing? Well, basically, they told you why you're not seeing your emergencies.
Exactly. Yeah.
Right? So
exactly.
Tell me now, why you are sitting there, tell me why you're not seeing your emergencies. Who are you scared of?
Well, if it's not the GDC, it's going to be the CQC. If it's not the CQC, it's going to be somebody else somewhere who's ready to attack, a lawyer or something.
Yeah, but you need to prove yourself. What is the main thing you need to do just now is prove that your patient didn't catch COVID from you.
Yeah.
That is the main thing, stopping you from seeing a patient.
Yeah.
Right? So that's the thing. Now, if you are a young kid today thinking of buying a practice, you're not going to do it today. Unless you are getting a very, very good deal.
Okay.
Right? And for those who are looking to buy or whatever, do not ever buy a practice that does not have a minimum of 10K NHS or plan income per month. That is the simplest formula of buying a practice. You must have a capitation income of 10K, then plan or NHS.
Okay.
Somebody's just made a comment here about dental insurance indemnity. Right, that was another thing. The only thing you need to check if you're doing emergency, because a lot of practices are talking about opening 1st of June. Private practices, Portman, etc. Are you covered? I saw a note on WhatsApp just now that TDC says you're always covered, but everyone is different.
There's another question on my WhatsApp, and I think Anwar has also put it on the chat. It's a very similar question. Basically, incomes are going to drop over the next 2 to 3 years. If there's a recession that follows, some patients might not be willing to spend a lot of money, recovering from the whole COVID process. Will prices go up in private dentistry? And if they don't, how can you increase your gross?
Well, increasing your gross is a multidimensional. We have got like 7 fields in our profession. It depends where you are. Now, if you tell Wazim, he can turn his gross around by doing, 100 Invisaligns. He's done.
Yeah.
Right? So that's because that's where he is. Are people going to start coming and telling you, I've got a 6 missing and I need an implant? Not really. Right? So certain things are going to be difficult to sell, but bread and butter dentistry will remain.
Also,
it will always remain.
I'll just add, it's also the value you put on dentistry as well.
Yes, I agree. On the patient's perspective.
If you explain.
If the patient's value
I think, yes, we will have 1 year or yeah. And it's how you talk to the patient and how you communicate. As I said, I think private practices will do very, very well. I agree.
They will do very well. I think they'll do better than NHS practice. It might have a difficult 1 or 2 months. They will do very well because they're already at that standard. You just need to move on. And you see, other people don't realize the graphics, if you like, of patients. See, a lot of people like us, we've been here 20, 30 years. And we are professional, immigration, second, first generation children. A lot of the indigenous population they are like a bus driver or a postman, but he's inherited a $500,000 house because his granddad bought it for $4,000. And you think he's just a bus driver. He is the one with the money. It's not the guy who comes to your practice in a Jag and parks outside. The guy with the money is a bus driver, train driver, postman. These people are sitting on houses and things, and they're earning 50K. A tube driver makes really good money. The guy who comes to you in a Mercedes will finance the treatment. You'll find a postman will just pay for it. Because in 3 generations' time, people will have inherited a lot of money. And the profiling of your patients when you're doing your initial consultation is very important. Don't judge a person by, beard or face like myself or whatever. You need to judge and look at the postcode. Well, I used to work for Wazim. He'll tell you the stories later. But anyway, I'm going to end it there. Just these are a few of my
There is one question on my WhatsApp, and it's actually a similar question to the situation that I'm in at the moment. I'm working in another practice apart from yours, and I'm maybe doing 1 day, sometimes 2 days a week over there. If we're going to have this downtime between patients and the practice only has 2 surgeries, is it not wouldn't it be easier for the principal to just get rid of somebody like me, an associate, and use the 2 surgeries, at least in this recovery period, to help with cash flow or things? Because if I'm doing the work and I'm taking a percentage of it, that's eating away at the revenues that the practice can make, not necessarily the profit. It's like you said, 2 months or 3 months profit growth is a whole year's profit. So would it make sense to get rid of the associate at least for a short period and then come back to think about it once this is over? Or is there value in keeping an associate, or is there a way around it?
Depends on the practice. I would personally get the associate to run the
I
2
think that.
Hello? Somebody was saying something? I think there's value in keeping the associate.
Okay.
Right? If you are running if you've got 3 practices, say, you're not going to run or work on all of them. Right? So if your associate is willing to work, you need a spare room if there's downtime, and get your associate to do what you'll be doing. You may need to reduce a percentage, maybe 5% for a year or 6 months, which most associates will accept, but you still got a job.
Yeah.
Getting rid of good staff or associates is the worst thing you can do. You might as well show a loss at the end of the first year and not pay tax, but keep your good staff, because in years to come, they are the people who are going to make you successful. What is your asset in the practice? It's just good staff. If they're gone, you're gone.
Brilliant. Perfect. No, that's great. Thanks. We've got Mazen here. So I don't know. He said he's available for question and answer. Mazen, can you hear us?
Yeah, Roshan. Hi, it's Mazen. How are you?
Brilliant.
Hi,
great.
everybody.
Thanks. We can hear. We can
I've
hear
got
you very
really
well.
bad reception. I don't have Wi-Fi, so I texted you to say that. So thanks for taking my call.
No, that's great. We can actually hear you quite well, so that's good. There was a couple of questions on how, if you think, one was, let me just get it up. One was, how are labs going to need to adapt? Do you think there'll be fewer crowns and more other types of work? And the second question is, can you see the prices of lab work increasing in the coming months or years? Or not years, short term, basically.
That's the big question for us. Are we going to have enough work to maintain our team? As a lab owner that I've had my lab maybe for the last 18 years, I built up quite a big team. I mean, the team is about 25 people. Am I able to maintain the team? They're very loyal people, people that I spend time training and educating and spending the best amount of time on getting the best out of them. I might be able to maintain the same team, or do I have to downsize the team? Downsizing the team, I mean, as you know, dental technology, no matter how digitized it becomes, is still a craft, and we need crafty people. We need people who can do nice work. So the question is, can we maintain the team with the amount of work that we're going to get after the COVID-19, during the COVID-19, or not? You know, that's one question. That is the big question for us, you know. So at the moment, as you know, we are shut, but we're waiting to come back to work. Obviously, we can't work without you guys working, and that's the main question for us. As a medium-sized lab, we work as a production line. We can't get rid of one technician to replace him by another, or split up the one technician's job to do two types of jobs. We have a nice production line that is productive, and it is producing nice quality work in a good amount of time. We're not taking very long to produce the work. At the same time, we're producing good quality work with the production line that we created over a few years. I mean, to get to the goal. With the COVID, do we have to downsize the production team? That is the main question for us. That is the main question. This is the main worry. I think digital dentistry will play a big role. A lot of dentists will have to switch the digital dentistry to minimize cross-contamination between the clinic and the lab if there is some sort of cross-contamination. And at the same time, the lab will have to go more digital. Okay, labs will have to go more digital, digitize more of their workflow. But the big question for me as a lab, without any guidance from the GDC or the Dental Laboratories Association or anybody else, what's next for us? You know, we just have to wait and see what we're going to get from the clinics in terms of work and amount of work. And then we'll see what will happen in the future.
Brilliant. No, that's great. Thanks. I didn't actually introduce you properly. So for those of you who don't know Mazen, he owns a Denzyme lab. I've known you for a few years, but actually this is the first time I've ever seen you. So I never knew what you.
Yeah, we've been speaking over the phone for years, but this is the first time we meet face to face. So this is one advantage of the Corona.
Exactly. Lots of Zoom meetings. Do you think the type of work you receive will change? Do you guys do any ortho at Denzyme?
We don't do any ortho work. We do some aligners. We obviously, as you know, my lab is quite digitized. So with 3Shape, they're trying to establish something similar to the iTero Invisalign thing to be made locally. We're working with 3Shape on that, but we haven't rolled it out yet. You know what I mean? That's the thing.
Brilliant. No, that's great.
Yeah.
Thank you very much.
No problem. No problem. Thank you, Roshan.
No, thank you. Thanks. Okay. So so last but not least, we have Mr. Ramid. I think he doesn't need any introduction. We've seen him organize a lot of these. He's the man I did my implant course with a few years ago. And he's a restorative consultant in all the individual mono specialties. He also has London Dental Academy. They run a lot of courses, and I've learned a lot through him. So, Mr. Ramid, if you can give us your insight on what you think we've been talking about so far, and you know what your perspective on things are.
Thanks, Rosh. That's a pleasure. And thanks for arranging this great event. And good to see all these nice people, Jitin, Monty, and Dr. Anwar, Faisal. Everybody is great, actually, and Maz. I've been working with most of you guys in the last few years. And I think from my own perspective, I'd just like to shed some light on the secondary care delivery, basically, service provision and service delivery. I think we will definitely have a lot of changes and already planning for changes. So all our SOPs now planning is about how to reduce AGPs. And as you know, most of our practices involved AGPs, especially in restorative dentistry. So we would expect in the next few months, June, July period, we will start seeing some patients. We're already seeing some patients. But I think my main focus will be on non-AGP procedures in the beginning. and to reduce the volume of referrals from the peripheries. From in Hampshire, for example, we have got catchment area over 1 million, 1.5 million people. So I don't think I'll be able to deliver any of the routine services I used to do or we used to do before. Unfortunately, probably we will do some consultation, advice, and back to the already stretched primary dental care services. I don't know how things will go in terms of those who need the NHS at this difficult time. i.e. I'm talking on difficult tooth work cases, difficult denture work, difficult implants, perio disease, let alone the fact there are some other patients and group patients like cleft. I don't know who's going to see them. People already in the system for many, many years for maintenance, for implants, or for obturators. Again, it's going to be very difficult. So from my own perspective, I think most of the patients will go back again to the primary care. And as Dr. Monti mentioned, I think the only option might be available, and I hope it's not going to be the case, but it's going to be the private sector. Because I think a lot of restrictions with the contract holders, the providers, and a lot of changes will take place eventually. I don't see any radical change in terms for practice, as all mentioned by the respected speakers. I think all our return will be gradual. Will take at least 6 months' time to adjust and to adapt to the current situation. The financial implications, I think we need to forget about it for the time being. I think we need to accept the fact that we are in retreating position, and we have to maintain what we've got at the moment. As Mas mentioned, 25 people, to keep them in the lab is a big challenge. At the end of the day, at the end of the month, is a big financial impact on the company or individuals working for that company. And I think the quality hopefully won't to drop as well as a result of if we decide to downsize our services. I think Jitin mentioned very nice piece of work he did in the States, and he talked about tele-dentistry. Probably I wanted to ask him, because that's quite important, and also was it Dr. Basil? We saw Wasim Basil as well in North London. How do you see this tele-dentistry work for, it's basically, I see it as a discipline specific, probably for sleep apnea or for consultation or for triaging somebody with TMJ disorder or whatever psychological fear or questions or impact on their daily life. You might get away with things. But in terms of doing procedures in the long term, as Monty mentioned, you need to get to the bottom of the problem. You need to see people basically physically to see what's going on. So how do you see the tele-dentistry will work? It works very well in terms of the education and training for people, but I don't know how the service delivery will work around tele-dentistry, Jitin and Basil.
No, you're absolutely correct. Obviously, you can't do dentistry through a screen. So, but if you break up your practice into, like somebody asked about how do you grow revenues? Well, the practice of actually doing the treatment of dentistry is a very small part of what makes up your practice. A lot of it, I mean, Wasim's talked about value. So a lot of it is how your practice interacts with patients, and then how that patient actually ends up doing the treatment that you specialize in or you like to do. So the tele-dentistry becomes an easy way for the patient to get to know you. It's non-threatening. They can ask you whatever questions they want, and yeah, Wasim's nodding his head, right? They can ask you whatever they want to ask you. So it's a way to actually get more people engaged in dentistry, to actually do more work than they would have, because we don't, unless we listen to our patients, we don't fully understand how afraid they are of a number of things. It's not just the drill. It's, oh God, I got it, the smell. Go ahead.
I was just going to say, it's also, if you look at the type, Jitan, you probably agree with me, the type of people that we see nowadays as well. Let's talk about the millennials. They're not interested in face-to-face. They want to be on the phone.
Yeah,
it's
convenient.
all about being on communication. It's literally on their phone the whole time. That is the millennials that we deal with, basically. Yeah. And if I'm looking at Invisalign, especially, that is the market for it. But slowly, that to them, that's what adds value. They don't want the hassle of having to come and see someone. And you're quite right, people are scared. And it's not just the drill, it's the fear of meeting someone, the fear of talking with someone.
Yeah.
Just have to take a tube journey into London nowadays, and everyone's got their head down basically.
And then specifically with, I mean, obviously I'm a prosthodontist, so I appreciate the fact that, you can't make you have to do a comprehensive examination. There's absolutely no question.
Yes.
And so when it comes to actually talking to patients about things that are fairly complex, when you, and Monty touched on it too, how do you assess whether or not your patient is going to do what you want them to do? And that's a multifactorial thing. It's not just whether or not you do a good exam. Some of the best dentists don't get to do the treatments they want because the patient doesn't end up doing that treatment. So where I see it being a part and a place in practice is allowing patients, it's lowering the barrier to seeing you and talking to you. And it's building that trust relationship before they're in that hostile environment. To them, it's hostile. There's a lot of, we've surveyed patients, and the biggest problems, the biggest fears they have, the biggest peeves they have are cost and convenience. They say it's inconvenient to get an appointment. It's inconvenient to go. And so if you can break down those barriers by having a consultation with that patient first, there is no question that you cannot make a diagnosis through teledentistry. And anyone who says that they can is walking a very thin line with Dr. Anwar, right? They're going to go see him and they're going to get in trouble. So don't do that. Follow the guidelines. The GMC has guidelines on how to do remote consultation. I think that we will, as dentists, we'll have to look at that and put in guidelines. So I hope that answers your question.
I think I'll just add to that, if I may, in that it's exactly that. It's breaking the barrier down. It's not, and I think I said in my talk that it does not replace a consultation. It never will. But actually, all we're doing is it's that one stepping stone. I mean, in 7 weeks, I've had 2 people call me about 4 implants and a denture, for example. And so I spoke to them over remote consultation. We had a quick consultation. They showed me the denture, and I said, look, this is how much it will be when we're ready to eventually go back in. This is what it is. And he, to my shock, he said, okay, can I put £100 deposit because I want to go ahead with you when I'm ready to do that. And that's the point. It's adding a value. Now I'm still going to see him for a consultation. I'm still going to do a scan, and I'm still going to do my dual scan protocol and everything. But this was just one way of breaking that little barrier to go.
Yeah.
And the main thing, you will find out who not to treat.
Exactly. That is very true.
Right?
That is
These
very true.
people that you've spoken to, they're all going to come and see you.
Absolutely.
But what you will learn from teledentistry is need the buggers you don't want to see,
Yeah.
all right? And you'll get rid of them before they come to your practice.
Coax them away to your best friend.
Yeah, it's a good way for patient confidence. I don't disagree with it. And I've been talking to Roche about implementing it. But the main thing is that one guy you don't want to treat, you need to find him before he comes to your practice.
Exactly. It saves you a lot of heartache.
Yeah.
Yes, Jitin, I agree. I think there is a role for teledentistry, and it's been, as you said, mentioned, the GMC implemented that for a while. General practitioners actually doing this for a while. There are a few companies involved in terms of arranging the video consultation, online consultation. The difficulty which I'm facing or I anticipating is seeing patient or consulting patient as a new patient. I don't feel comfortable talking to people over the phone or having a video conference or online consultation unless I see them personally, assess them in person. I agree with Faisal. There are some items, again, we go back again to the discipline specific or the treatment specific, like Invisalign, it might be possible to visualize what's the problem, whether you can do it or not, whether you can take it or not. But for, I would say complex, even for routine consultation, you need to have a feel, you need to have the touch, and the human touch is quite important in order to give the patient some concrete conclusion of your consultation, because people at the end of the day, you could have spent like half an hour or 1 hour over the phone. But again, you tell them, I need to see you. I can't. All that's subject to 1, 2, 3, or that is, I would say, provided 1, 2, 3. So it's nothing set in stone. And
I'm sorry to interrupt you here. Can I interrupt you with something here?
who's that?
Yeah. Murtaza, he's a specialist orthodontist
yes.
in London.
Right. I'm sorry to say this, but this is not anything other than a mindset change, okay? I have the largest remote monitoring practice in the whole of Europe with 700 patients in treatment at the moment, okay? None of my patients have stopped their treatment throughout the whole of the COVID. Okay, I haven't started a single patient for new treatment, but every single one of my patients is still in treatment, still paying me, and still going ahead with their treatment, okay? And our Invisalign patients only need 3 appointments from start to finish, okay? It's a mindset change. We only do 3 appointments in the surgery even before COVID for Invisalign patients, because you don't need to. Everything else can be done remotely. And when I go back, I'm not going to do any consultations in person. I'm planning on hiring a dentist to do the actual examination, so I never bloody go back to my practice.
He's over here. Some of us are over here, and we got to meet in the middle.
Yeah, but that's
Murtaza's
fine for
correct.
Invisalign,
It's
but restorative work,
Yeah.
Now,
surgical
so-
work, you need to be in
I accept
practice.
restorative work is not the same. I
Yeah.
totally get that. I
And that's-
totally get that.
And
But
that's
what
where
you guys have got to remember is it's a mindset change that's the
It
issue
is.
here,
Yeah.
not the actual process itself. So I was seeing my patients every 4 weeks, every 6 weeks for adjustments. These days, I don't see my patients for an adjustment until the tele-dentistry tells me that they're ready for it. And you know what? The results are better. The compliance with tele-dentistry is better than anything I've ever seen, right?
there you go.
Because the pixels pick up the aligner fitting better than my eyes could ever pick it up, right? So my point to you is, yes, it's going to be different for restorative, and yes, it's going to be different for implants and all those other things, but it is a mindset change as well. It's not just about saying this can't be done. It can be done. It's just about adapting. And I haven't done a filling or an implant in ever, right? So I don't know exactly what the workflow is going to be for implants, but I'm telling you that in ortho, we have gone from a completely, in surgery now to an almost completely tele-dentistry setup.
Yeah, I think
And it's going to get to the stage where I don't actually need very many staff to do this anymore,
I
right?
agree with you.
I have lost 25% of my staff through natural wastage because of tele-dentistry. I haven't got rid of anybody, but I've just let people leave.
Murtaza,
And-
I think you made the point. I think there is an impact on workforce, as Monty mentioned. You need to keep staff. You need to keep the momentum within the practice, but within this type of business. And if you're only dependent on Invisalign and business rate to Invisalign, you would lose your staff and you would curtail your service.
Sorry, Shihab, the money, do you charge the same amount of money for such consultation as if a patient seeing a patient in a dentist in person?
They don't charge for consultation.
You should, yeah, you shouldn't. I don't think you should probably. It depends on what you're doing the consultation for. If you're doing a consultation because you want to sell treatment, or you're trying to get a patient to do elective procedures, Invisalign, veneers, composite bonding, things like that, I wouldn't, because again, it reduces the barrier to the patient actually ending up doing treatment with you. So you want to reduce the barrier as much as possible. And then going back to the question about, it is, Murtaza, you're correct. It is a mindset change over a period of practice. I have changed my mind several times about how I should do things. When I was fresh out of PROS program, it all had to be very much by the book. I've got to do it this way, and this way. And you soon realize that that doesn't always work, because there is the aspect of business as well. So my restorative colleague, I feel you as a prosthodontist that yes, there is no way that I could have a meaningful conversation about treatment options without seeing the patient. But can I dispel a lot of fears and myths about what the patient is thinking in this consultation before I see them? Absolutely, I can. That makes my time in the chair much more efficient. That I've already established with the patient that I'm an expert by the things that I tell them before I start poking them. And it's that opportunity that you miss in a clinical setting, because you're so comfortable going in and talking to a patient in the chair and getting into their mouths, that you miss that opportunity to really build that relationship. And that's actually what tells the patient has no idea how good your preps are. I realized that because I saw some really funky crowns, and the patient's like, he was the best dentist ever. And I'm like, okay, but I can get my sickle scaler in between the margins. You see, it didn't matter. They don't know how good I am. They only know with my relationship with them. And this is a way to...
The workforce in the UK, over 90% of delivered the primary care dentistry, and primary care dentistry probably over 70 to 80% delivered through the NHS. How do you see the NHS dentistry will work through this type of service, or this type of new, I wouldn't say new, but using this technology to be remunerated properly through their contracts? And Monty mentioned here quite important fact that post-COVID might be a game changer in terms of how the private dentistry will play a role, and also the new contracts, or probably the changes of the contract, might be impacted by this crisis.
I think that's a very good question, and honestly, it's a nut that we're trying to figure out. And again, it rolls down to Murtaza's point about a mindset change. I think that the practitioner themselves is going to have to decide, how am I going to, in an NHS setting, my costs are increased because I'm probably going to have somebody's going to tell me how I have to prepare myself in the practice. My costs are going to increase. So the practitioner is going to have to figure out how they're going to make this work economically, and whether or not the NHS steps up to solve that problem for them or not. I'm with Monty. I don't think they're going to. I think that I agree with him that this is why nothing concrete has come from them yet, because it's a big problem. I mean, I was in dental school a long time ago, and even then, the community dentists that were teaching were talking about how expensive it was to the NHS to handle dentistry, and every year it's been the same. I've been away for 25, 30 years, and I come back and it's the same problem.
Absolutely, getting worse, Jitin.
It's getting worse. So I'm with Monty. I'm like, I think something's going to have to happen, and I think they're sitting in the halls, and I think they're a little worried. I would be.
And Faisal, how do you see the Tier 2 contract working in the post-COVID or during the COVID crisis? Especially, you have got a big intake in terms of the endo, IMOs, and other services. Do you reckon that this will be stopped completely and diverted to some other providers like hospitals?
No, actually, I think the opposite. I think I agree with Monty that the core services are going to suffer quite badly, because I think all those who are sitting on big NHS contracts at the moment are probably thinking, well, we're the most secure. Well, actually, yes, you are short term, but not long term, because how are you going to deliver these UDAs? But actually, coming to your point about level 2 contracts, I actually think level 2 contracts have got this is just an opinion, have got a good future, basically. And I think the level 2 contracts, because if you think of a tiered service where you have a core service, and then you have those who need endo, those who need oral surgery, they can be provided for, but anything more than that is probably not going to be able to be funded. That's just an opinion. That's not a fact. That's what I think will happen. So I think level 2 contracts, yes, they will put the value into it. And also, don't forget that, you know, there's a startling fact about something, in that I think, if I'm not mistaken, what the net spend on NHS dentistry in 2006 and the net spend on NHS dentistry in 2020 hasn't changed.
No.
It's exactly the same. Yeah. And this is, so what does that tell you? That they're not interested in the changing needs or whatever.
No. Sorry to interrupt you, Azim.
Yeah.
Level 2 treatment without good level 1 base general dentistry won't work.
Well done.
Right?
You need level 1.
You need good level 1. Sorry.
Sorry, go Monty.
There's no need. You won't get a referral on level 2 if level 1 is no good.
It's functional.
It's level 2 will fall apart, number 1. So level 2 will not be procured if there is no level 1. Because the level 1 will be the ones referring to you for level 2. So it's important for them to keep level 1 good. Can they afford to? When we got the contract in Croydon, I asked the commissioner about 5 years ago, what are the chances of our UDA values or contract values going up as we go further or ask for more money? The simple answer was, we got too many kidneys and hearts waiting. Values are not going to go up on the GDS. So those who are dreaming about it can forget it.
I actually disagree. I think the source of the, you're looking at it as a source of the level 1 and level referrals for level 2 coming only from level 1. I think they'll have to redesign the whole system, basically.
Aha.
And this is the
that's a different ballgame.
Yeah, but no, this is the whole.
We're going back probably to the point that primary dental contracts might not be exist in 5 or 3, 4 years.
Exactly.
Now, but in the long term.
Yes.
Okay. People are going to fast.
Monty,
break the fast.
Rosh, can I come in for a second? I just wanted to query Jiten about this tele-dentistry thing that he's trying to talk to us about. I just want to get my head around this, because there are some issues. Sorry?
He's been selling very hard his idea. I don't know what.
Yes, I know. No, I want to get my head around this, because this electronic thing. How are we gonna control privacy, security? How do you get consent? There are different standards, there are different qualities, different safety mechanisms. Is it very efficient or not? These are all the kind of things that medical legally, gets into my head. And I can't get my head around this. So maybe you can throw some light on that.
Yeah, absolutely. I mean, security is a big issue. Okay, and that's why it's not as simple as picking up your phone and having a WhatsApp conversation with a patient. So these are things that we're working on. We have to develop. And I'm very happy that Roche asked me on this call, because to a greater extent, I really want to understand what difficulties we have, the things that we should watch out for, the things we have to be careful of. So I totally respect 100% that there is a situation here where you have to maintain patient privacy. So in the US, you've heard of HIPAA, HIPAA, the Health Insurance Portability and Affordability Act. Well, that is specifically centered around patient security, patient health information, PHI. So there are specific guidelines on this. And in the GDPR is much more wide based in terms of information and what needs to be done to secure that. So there has to be, to make sure that dentists and patients are comfortable and confident that the means by which they are interacting with each other is safe and secure is very important. I agree with you 100%.
But everything is in the cloud, isn't it? So, and cloud is so easy to hack.
Well, yes, but no, yes and no, because this is a situation that, unfortunately, you are correct. For as long as there are systems in place to put things in the cloud, there are people who are trying to attack the cloud. That is correct. But let's again, it's a mindset change as well to a degree. When you're in a room with a patient, is your surgery set up so your receptionist answers the phone, and you've got people in the waiting room? How secure is that? How much information are you talking about with another patient on the phone that another patient in the waiting room can hear? When you're in one consultation room, can somebody in another room hear you? So we have to understand that.
But Jiten, 2 wrongs doesn't make a right, right?
No, I know. And what I'm trying to say is that actually, I'm actually trying to say that in a digital environment, there's actually more safety, because this is where you have to have an encrypted video. Because, sometimes with, some of you may have heard that recently with Zoom, you had some Zoom bombers.
Correct.
Right? And that's why in this particular instance, we have to be, as we develop this and we build this, That's why you have to be careful about who your teledentistry provider is. Have they thought about these things? I'm with you 100% that this is the thing that needs to be worked out and sorted out, because you have to have the ability where nobody walks into your room. You have to have a place where when you're securing documents, it's as secure as it can be. So Microsoft Azure and Amazon Web Services have gone to great lengths, spent billions and billions of dollars on developing secure servers. You can't host this on a GoDaddy server. So these are the things that are going to have to be. This is how you're going to again, it's value, and it's now determining who is your teledentistry provider going to be. Is it going to be someone who just put something together in a garage and just put a couple of things together because you can pick up the phone and a video and put together? Or is it going to be somebody that has considered all these things that, and again, that is one of the problems. You're right. It is something that needs
I think also the issue about vulnerable patients is another issue. Because how they can be exploited, in a system when you're not having a one-to-one non-verbal communication presence isn't there. So how do you know you're talking to the right person, for example?
Help me with that a little bit. Just take that a little bit further.
With dementia or Alzheimer's or any sort of
Because you don't have any non-verbal communication available, right? It's like you're doing it remotely, and what guarantee you have that you're actually speaking to the right person the second time round or the third time round you're dealing with? There might be vulnerable people who could get onto this system.
Mental capacity without be there to comprehend your consultation or the questions you ask or the things you ask from the patient to elicit to make some sort of decision based on the information you get from the patient.
Well, that's why I think a video is better than no video. Like, it's better than the telephone. It's not really. Again, look, it's in terms of what you've said about your duty of care as a dentist. If you are in a situation, so I feel uncomfortable talking to a patient on the phone that I cannot see about something that I cannot tell how they're responding to what I'm saying. When I look at them, do they look away? Are they paying attention? Did I just say something that just caused a reaction in their face? So there is, in none of this is teledentistry a substitute for seeing a patient face to face, except if you're Murtaza Hussaini, right? But it is not a substitute. It is a way to provide a level of service to your patients. Make patients who might be uncomfortable coming to you straight off the bat and seeing you in your office in a non-threatening way. Is this how it's always going to be done? No. It's not a panacea, but it is a tool. It is a way.
Great. Anwar, may I ask you a question about you talked about dentists. We have got DCPs, about 10,000 people in the UK. How any of the regulations would have any impact on the hygienists, dental hygiene therapists, nurses, dental technicians, clinical technologists?
Sorry, come again. I didn't quite understand the question.
You talked a lot about the regulations in relation to dentistry and dentists in general, delivering services.
Right.
DCPs working under or along dentists, like hygienists, dental hygiene therapists, dental technologists, and clinical technologists. So how do you see because nowadays I advise patients who have a problem with their dentures to go and see one of the local clinical technicians to help with the problem and to save some time and money for the patient rather than coming long way, like 70, 80 miles to come and see me for something simple or a service which is not available at the moment.
I'm still not 100% sure whether I actually get to what you're trying to say, because the GDC has got regulations for the dental care professionals that includes the hygienists, the dentists, the nurses, and also the technicians. So what is actually you are trying to ask? I'm not 100%
If
sure.
somebody has got a problem with his dentures, for example, and needs some,
Right.
or some new dentures being made, and seeing within this current climate and the regulations and people offering their services to help the community as such, how do you see that is going to happen from GDC point of view if something goes wrong with the treatment being offered by dental technicians or
I think the dental technicians are not really permitted to take impressions and make dentures.
They are the clinical technicians.
Clinical dental technicians are allowed.
Yes.
Are allowed to. Okay.
Yes.
Okay. Then obviously the status quo would remain. I don't think any. There will be a bit lenient under the circumstances if something did go wrong. I think that's the general vibes that we're getting from the General Dental Council.
I mean, seeing patient and doing clinical procedure on them rather than technical procedure.
I think clinical procedure, that would create a problem. I'm pretty sure.
Well, if it's an emergency, yes, but if it's just treatment, they might not be allowed to do so. So somebody broke a denture and they go to a CDT to have it fixed, I'm sure that's fine.
Yeah, that's acceptable. That's acceptable.
Yeah, but if he starts making a new set just now, that might not be acceptable unless there is no other choice.
Yeah. And what do you see? How do you see the role of, now we have got 10,000 people within the slowdown and the whole, I mean, they don't have contracts. They don't have any sort of legal employment at the moment through the NHS contracts, whether it's the primary or secondary care. How do you see the workforce with the dental hygienists and hygiene therapists would work in the next few months or years to come?
I think it's going to be a difficult time for everybody, really. It's not just the hygienist and the other workforce, even for dentists. I mean, I put up a question about what's going to happen to dental practices themselves, because people or patients are not really going to be willing to visit dental practices that soon. I think the workload is going to come down. Initially, it'll only be emergency treatments, maybe treatments where people are really halfway through treatment. All the elective treatments, I think, will probably take some time to settle down, maybe at the end of the year or maybe next year. And the same thing will happen with hygienists. I don't think many people want to electively go and visit hygienists as they used to before in the past. You know, pre-COVID, the way that the systems were working, I think there's going to be a slow rate on that.
You might be surprised.
Yeah?
You will be pleasantly surprised.
Do you think they will be able to play a role in tele-dentistry, helping dentists consultation, like oral hygiene instructions, or?
Yeah, I think
even with,
because if you look at the mapping that the NHS have done for redeployment, they're actually talking about things like that as well. So they will be able to be redeployed into other areas of giving oral hygiene advice or applying fluorides and things like that. Yeah, so that should be possible.
The other thing with the hygienist, I was thinking that will there be any financial implications to the practice in hiring a hygienist? So say, for example, Monty is hiring me to do filling on a patient. I've already got a nurse, I've already got my PPE, and I've already got a rapport with the patient. Would it make sense for me to just do the hygiene visit at the same appointment, or will there still be a role to have a separate filling with me and a separate filling with the hygienist?
Wasim, can you answer that?
Yes, Monty or Wasim to answer. I'm out of the game at the moment. So.
I hope I haven't changed.
I think you know, and I think this is also probably going to answer one of the questions that's come through in the chat. I think there's a short term, and then there's the medium to the long term. So I think in the short term, yes, maybe it might be more sensible for the person doing the filling, and you have to be practically and almost going back to the old days, try and get as much as you can done in one session, basically, because you want to be as productive and whatever. And I think in the long term, I think, as I said, it's just about adapting, and we'll change and we'll work, and there'll be a role again for as we want to do it, basically.
Thank you very much, guys. I'd like to ask Jitin before we finish the session, because it's quite important. Now, we talked about the role of dentists and specialists and therapists in contacting their patients or in getting the stuff marketed and getting things, setting the scene for treatments. Do you think there is any chance or development, in-pipe development at the moment for patients to search for their favorite dentist or dental practices to ask for specific items or treatments? And how did that
I mean,
work? The other way around.
Finding a teledentistry platform in which they find the dentist through,
Well,
find a dentist through a teledentistry platform.
they have got the choice, and they look for example, somebody wants to have a radius like Uber, for example, to select the car, the driver, and the service you want to have, basically. Is there anything in the pipeline in terms of development, and how do you envisage such service to be delivered?
Well, I think how that service is delivered is going to depend a lot on whether or not it's a needed and wanted. So what you've described is something that we've thought about, but it really depends on, are people going to do it that way? Is that what's going to happen? Certainly, it's possible that patients would, like right now, you can't stop a patient from Googling the symptoms they have. And in fact, I had one person call me and she said, you know, this is what I think I have. And I spoke to her a little bit. She's actually a staff member in the practice.
Yeah.
And she had a tonsil stone and she Googled how to get rid of it. So she was doing this procedure in her mouth, watching YouTube videos on the internet.
Right, interesting.
So I was like amazed. So I don't think we can stop people from doing that. I think people are going to do that. And so my opinion is that it is far safer for a patient to interact with a qualified dentist and then be given. So the role of this service could be two things. I don't know exactly how it's going to be. If dentists are enrolled on the teledentistry platform and they have particular services that they provide, is the patient going to be matched with these different providers? It's a possibility.
Visibility between two parties, and giving the dentist, you can call your patients, basically just give them a notice. But for patients to call somebody from scratch, as a new healthcare professional, I don't know.
It would be possible. And then, you know, I've thought about how could you match a patient's needs with a dentist, right? So again, it depends on what patients feel that their biggest problems are. It depends on how dentists perceive the value of being able to speak to a patient before a patient comes in. So these are all things that could happen.
Do you think the insurance company will play a role in terms of getting these type over online consultation or discussions in terms of supporting some group of patients who are interested in such services? Because you can't spend all your time just doing online consultation or giving people advice.
Yeah, exactly. And I wanted to ask Dr. Anwar, okay, so what are your concerns and what would you like to see happen or not happen on a teledentistry platform? From your official standpoint, what's your worry?
I think it's a very good tool for using for information seeking, for communicating with the patients, to pre-arrange things. There are quite a lot of modalities you can do. My main issue is about the fact that this electronic storage that takes place, how can you make it so private and secured that it cannot be hacked? That's my main worry. What does data protection law and act say about it? Because I haven't actually gone into that in more detail.
Oh, okay.
But these are my worries. The second worry is about consent, about how you can actually get consent and how you can store consent. And also I'm worried about the different manufacturers who may be available trying to promote this particular idea. So there'll be variations in quality, in safety, in efficiency. So what standards are there to protect this particular teledentistry? Is there going to be a body that will make sure that the standards are adhered to, that there are actually some standards that everybody will have to follow? Or is it just going to be somebody in his own garage having a PC and a bit of equipment and a few wires going around, and that he'll be able to sell this particular product. So basically, these are my worries.
Okay, cool. Can we? I'd love to hash those out with you. We don't have to do it on this particular platform. I'd love to, but I think those are all addressable, and I agree with you wholeheartedly on them. So I think they are legitimate concerns, and I think they should be addressed for sure. And I'd love to discuss that with you.
Yeah, sure.
Great.
Great. I think, Rosh, do you have any further questions from the audience? Anything else you want to discuss? A lot of questions, but I think it's difficult to accommodate everything in a very short session.